Hi, now we are going to discuss about Sweyer syndrome. I am Dr. Priyanka from NEXTFELLOW. What is Sweyer syndrome? It is a disorder of gonadal dysgenesis with 46XY karyotype. A few points on gonadal dysgenesis. It is defined as an incomplete or defective formation of the gonads. It results from a disturbance in germ cell migration or organization. Gonadal dysgenesis is commonly caused by structural or numerical sex chromosome abnormalities or mutations in the genes involving formation of the urogenital ridge or sexual differentiation of the bipotential gonad. Due to the absence or accelerated depletion of ovarian follicles, the gonads contains only stroma and appear as fibrous streaks. Large majority of patients with gonadal dysgenesis have an abnormality involving X chromosome. The most common known form of gonadal dysgenesis we know is Turner syndrome. But in 10 to 15% of the patients, mutations of the SRY gene that is located on the short arm of the Y chromosome is seen. So, Sweyer syndrome is distinctly different and less common form of gonadal dysgenesis with 46XY karyotype. So, let's discuss about Sweyer syndrome. The phenotype in Sweyer syndrome is female despite the presence of Y chromosome because the dysgenetic gonads produce neither AMH nor androgens. The internal and external genitalia fail to masculinize in these patients. The vagina, cervix, uterus and fallopian tubes develop normally. Patient presents after the expected time of puberty with delayed sexual maturation and primary amenorrhea. The presence of pubic hair rules out complete androgen insensitivity. They have normal adrenarche. Evaluation reveals hypergonadotropic hypogonadism with high levels of FSH and LH prompting a karyotype which shows 46XY chromosomal pattern. So, how do we manage Sweyer syndrome patients? Gonadectomy is indicated soon after the diagnosis because there is significant risk for malignant transformation in occult testicular elements. It is around 20 to 30%. The patients exhibit normal growth and intellectual development. They are healthy and require no specific monitoring or treatment like Turner syndrome patients, but they need hormone therapy which aims at inducing sexual maturation. We start estrogen therapy at a very low dose at 0.25 to 0.5 milligrams and increase gradually at every 3 to 6 months according to the response. We see the Tanner staging with the goal of completing sexual maturation over a period of 2 to 3 years. Progestin should be added to the treatment. When should we add? When vaginal bleeding first occurs or after 12 to 24 months of estrogen therapy. This regimen prevents dysfunctional bleeding and achieves differentiation of breast tissue and protects the endometrium from long-term effects of unopposed estrogen. Patients must be assured of their female gender identity and reassure them about the ability to achieve and sustain a pregnancy in the future with the use of donor egg IVF. With donor egg IVF, they can bear children. Thank you.